all of you. So, so today it gives me immense pleasure to back to with the ocular trauma presentation, which we have been privileged to conduct again here in Cochin. So now, as you know, the my topic assigned to me is very specific. It is just gives us a overview of corneal tear repair, the principles and the management. So with this, I have to proceed. I have no financial interest for this presentation. This is a global incidence. You can know that WHO has described about 55 million people usually experience this ocular trauma every year, and it average 2 to 3 lakhs people by number they come into play for this ocular trauma management. So blindness is the major cause of unilateral blindness, and this mostly occurs in the younger individuals with the age group of 25 to 30 and of about. And this is how the patient comes to us in the ocular clinic. And when it comes to the eye clinic, so you can see the various layers of eye is involved, and you can also see the various zones of the globe which is involved. So accordingly the management differs, but the basic thing is that the history taking is the main cause, main thing which you have to really make sure that you elicit it in the way of like mode of injury and the activities they or as he or she was doing, the velocity of projectile object which hit, or is there any scope of sterile trauma or infective trauma, is there any risk of retained intraocular foreign body, or the trauma with any vegetable matter, or like risk of endophthalmitis or aggressive treatment management in specific cases is needed. So visual workup starts with the visual acuity, and then with the pupillary reaction has to be is seen, and before that we should install a topical and anesthetic drops so that the patient really comfortable to cooperate with us. Slit lamp as far as possible is mandatory. Fundus examination is optional, of course. Sedal test has to be done when you think there is a leak in the antechamber, from the antechamber, and then imaging to diagnose and management. So X-ray is the basic test which has to be done in all medical legal case, and this will locate the radiopic isodens foreign body in the orbit, and also will give an idea about the orbital rim fracture. Simultaneously, we need to go for a CT scan, which is the gold standard for the treatment, because it helps to localize and helps to detection and detect the foreign body, and also characterize whether it is metallic or non-metallic foreign body. However, the sensitivity differs from 50 to 70%. These can also aid in the assessment of the localizing foreign body. Also, it will give a assessment of the posterior segment and the degree of damage. Other modalities can be ultrasound biomicroscopy and gonioscopy can be selectively done when we see a foreign body or you suspect a foreign body in the angle. MRI is absolutely contraindicated in metallic foreign body injury, but more effective MRI is in localizing non-metallic foreign bodies or wood, vegetable matter, or plastic. So pre-op management starts with the tetanus injection and systemic antibiotics, so the fluoroquinolones and third generation cephalosporins. Then on basing, after having this started, then you can decide whether to go for a conservative management or surgical management. Conservative management mostly is preserved for the lacerations or the wound which is less than 2 millimeter, and there is no intraocular tissue lodged in the wound, or in the foreign body is not lodged in the wound, and there is no other structural damage of the eye. And residual states can be negative, but precious residuals might be showing positivity. But of course, the contraindication would be in the children and uncooperative or mentally challenged patients. So surgical management, the goals as to restore the structural integrity and the restoration of the visual optimal function. So it also helps to manage the posterior segment pathology afterwards. So Next, coming to the principles of corneal suturing. First principle is the selection of the suture material. That should be monofilament 10 or 9 sutures with a reverse cutting spatulated needle, which has to be hold at the junction of 2/3 and 1/3 of the needle. And next will be the selection of the suture material. So selection of the material will be 10 or 11 nylon for corneal injuries. Scleral injuries is 8 to 9 nylon, and conjunctiva is always with acrylic. Simple interrupted sutures is always advised to go for this type of suture. 311 or 211 sutures are done with the knots to be being buried in the superficial area, not at the wound site. So principle 2 is the depth of suturing and the angle of suturing. Depth of suturing is to be 90% depth, as well as it has to be perpendicular to the corneal wound. And if it is a clean cut tear or a linear tear, the equal depth of suture should be assessed in both sides of the wound. So coming to this routine schematic diagram, you can see this is a normal A picture shows the normal suturing with a good depth and symmetric suturing in both the sides. There's picture B shows the asymmetric suturing, the symmetric suturing looking like, but it is a not full thickness suture. So it is a not full thickness, not also adequate suture. So it's a shallow suturing. Shallow suturing will lead you into a posteriorly gapping. And then third C diagram shows you the full thickness suturing. And in a trauma case, if you have a through and through endothelial through and through suture, then it will leak after the AC is formed, and also that is a chance of infection through that port. And D and E shows the asymmetric suturing, irregular suturing, which will lead to either posterior surface or anterior surface overriding. So this is the diagram showing part A is the best suturing of the good apposition, and the B picture shows the overriding of the edges. So coming to the principle of third principle, this is for only for lamellar or self incision. The principle here is that when we do a suturing for this, so we have to oppose the posterior lip equidistantly or symmetrically. Whether the anteriorly or from the surface, epithelial surface, it looks abnormal, that one small side, one is a small end, one other larger end. So ideally is that we should aim at the posterior segment symmetry, not the anterior side or epithelial side symmetry. And here when you bury the knot, it has to be the thicker side, not at the thinner lamellar side. Next, once you put one suture, then you should always remember about the principle of zone compression. So this is both the sutures. When we suture, one suture is over, when the second suture, you go for the second suture, and there the distance between the two sutures only maintains the zone of compression. Ideally, if the zone of compression overlaps each other, then only you will have a watertight compartment. If the zone of compression doesn't overlap, you can see the picture B, which shows the wound leak. This is the picture of a good zone of compression and watertight suturing, and this is how if you suture the second, it will be cramped suturing. Then principle 5 is the suture placement strategy, and ideally that goal is to compress or flatten the periphery with the longer sutures, so that the center sutures which are in the visual axis has to be smaller and just well opposed. We need not tighten it, minimally opposed. So linear tears involved in the visual axis, and this is the linear tear. You can see the video, and so principle of no touch technique has to be followed in all these suturing cases. So ideally we should make this is not an ideal this thing, I am showing knowingly what is has to be done probably this case to start with. We should have done a side port and put either pilomine if it is lens status is seen clear, or you have to put side put and do the visco elastics and then start suturing. Ideally speaking, suturing should start at the limbus and then at the angles. Thus I'll show you the principle of suturing next. This is the principle of suturing. So these are the anatomical landmarks actually. So here anatomical landmark is the limbus is one of the landmarks. Then the vessels or the pigment line epithelium and the cut angles or the laceration angles. So we have to suture always at the in this case we don't have any anatomical landmark is the laceration angle. So we are suturing the laceration angle. Here also we could have started at the limbus first. So limbus has to be done first and then go inside the cornea to manage. So coming to the corneoscleral injuries, this is you can say this and that once you have got this case, you have to see whether iris is prolapsing or not. If there is iris no prolapse, you can suture either way, either from this limbus towards the sclera first, or if there is iris prolapse or there is vitreous in the AC, once you cut it, then you finish the at the first suture at the limbus and then second suture subsequently into the cornea if there is iris prolapse or vitreous prolapse. If there is, but this case there is no iris prolapse, so we have decided to close either way. Wherever we suture is okay for us. But this is the stellate laceration, and this is always a nightmare for all the surgeons. We have to assess the apex of the wound always because that is mostly lacerated. Usually we see this type of injuries when we have a bottle injury, glass injury, the soda bottle like this thing, or that stone injury, blast injuries. They will always have a irregular stellate injuries. So this can be addressed with intermediate bridging sutures with central purstring sutures. So corneal lacerations with iris prolapse is the one more entity which you have to always think about before the suturing, because before suturing either the prolapse iris has to be reposed back or it has to be excised. If it is less than 24 hours, it is always almost always healthy, so it can be reposed back. If it is unhealthy, even if it is less than 24 hours, it shows the signs of necrosis and maceration will be there, and then infected rim or infected edges will be there, then we should excise it. And of course if it is crosses beyond 24 hours, it has to be excised. So post-operative management, topical antibiotic, antifungals, judicious use of topical steroids, cycloplegics, and posterior segment evaluation has to be done. Suture removal, however, is ideal to do at 3 months, but anyhow, any loose sutures or broken sutures has to be removed. Sequential suture removal can be done for selective tight suturing remove, and then overall the refractive correction has to be given after 1 month of all sutures are removed. So main thing here is to how to prevent. So prevention can only be the best thing for the getting the cure. So this counseling should be done to not to get the similar trauma in other eye or the same eye again. And the protection of the eye has to be done with special glasses or any special measures should be taken in the employment side. And counseling of the visual outcome post surgery also is mandatory, because it is a globe and it has got all other every structures of the eye is involved, so the visual outcome should be clearly explained to the patient and also attender. In practical purpose, we have seen that 30% of the people lose about 30% of the vision even if the surgery is done perfectly all right, even if a lens is put, even if there is no retinal hemorrhages or no retinal breaks, the 30% of the visual outcome is lost, and that has to be really emphasized before the surgery itself. Thank you for your kind attention.
Thank you, sir, for your talk. I think you have covered most of the points of 5.